Welcome, everybody. I'm going to give us just another minute to let people keep joining the webinar this morning. All right, welcome to our September webinar. We're so glad you guys are all here. Just a couple quick announcements and reminders here at the beginning. First of all, this webinar is being recorded and will be uploaded to our resource library once it's concluded. So you guys are welcome to watch it there and share the link with anyone who wasn't able to make it live. We do also, there's an option to turn captions on if you'd like to do that. It's just going to be on the bottom part of your screen. You'll see a little button that says CC for captions, and you can turn those on there. And then you'll also see down there a Q&A button that you can use to submit any questions you have throughout the presentation. We will be doing a live Q&A at the end, and we would really, really love to be able to answer your questions. So submit them there. You can submit them anytime throughout the webinar. And then just a disclaimer that this is an educational session and is not intended for the purpose of providing medical advice. Next, we just want to mention really quickly that our online community, MSA Connect, has just moved to a brand new platform that we're really excited about. It's got a lot of really exciting new features, and it's just a lot more user-friendly than our old MSA Connect platform. So we will be shutting down the current platform on September 24th. So be sure to visit missionmsaconnect.org, sign up for a new account on our new MSA Connect platform. It's really great and really exciting, and don't hesitate to send us an email if you have any questions about that. We are so excited that you all are here today and that we have our awesome panelists here to talk about building a care team and just the importance of having different people on your team. And I will let them kind of introduce themselves as they get going, but I am going to hand it over to them now.
All right, thank you very much. So we're happy to be here today, and we are going to just do brief introductions, but let me share my screen so we can have the importance of this topic. So this will be a continuation for everybody that was able to join us for the International MSA Congress. We had this initial topic with some cases to discuss, and that's the ones that we're going to follow today. So we actually are going to start with the cases that we didn't cover during the last session. And I am here with Amy Cooper, who is a neurology provider at Vanderbilt. And then she will be talking along with us about the role of neurologists and also chiming in a little bit on how to manage urinary dysfunction. And I'm here also with Stacy McCauley, which is a speech pathologist. And she will be talking to us about, all the other important strategies with speech and swallowing. And hopefully we also have Rhonda, which is our physical therapist, joining in. If not, we're going to tackle them as we go. So any first words that you guys want to say?
Happy to be here.
All right. We're going to move forward to see and try to cover most of the cases if we can, because there are some specific topics and learning objectives that we have for these. So we're going to go ahead and start with the question, what's the importance of building a care team? And we realize that multiple system atrophy is not just a one-man or person disease. It requires a village in the sense of multiple interdisciplinary areas working together to help patients with multiple system atrophy at different levels. These include the neurologist or neurology provider, also physical therapy, occupational therapy, urology, case management, or social work, but also family members, caregivers, and other supporting people around you, and also speech pathologists and psychiatric and mental health counseling. So we will try to address the main difficulties on each of these cases and trying to address some of the main difficulties that this patients presented during the cases. And we will have time for answering questions at the end. So feel free to put your questions on the chat and we will address them at the end of this presentation. We will start with case 1. So this is a 70-year-old female that presented for evaluation of progressive imbalance and slurred speech. 2 years ago, at the age of 68, she had an onset of walking changes with some exaggerated impairment with alcohol. So she will have significantly worsened gait or walking when drinking a glass of wine. And then her first fall was a year after symptom onset, and she reported at the time that was having some dizziness. She also had some other issues, including constipation and difficulty emptying her bladder and dizziness, as we mentioned, and getting out of bed in the morning. There was an extensive laboratory and genetic workup prior to evaluation, but really didn't find any cause for ataxia or abnormal with coordination and gait. After those 2 years, on year 3 of disease, the patient had worsening gait and worsening urinary dysfunction. She started requiring a walker or a cane and had worsening urinary incontinence as well. She had a bladder scan that found 140 milliliters of urine retained. So she started doing some self-catheterization. At year 4, further decline on speech and urinary dysfunction with moderate to severe dysarthria or difficulty articulating words, and made it very difficult to communicate. She started falling even more, and typically these falls were associated with postural dizziness. So she was started on a medication called midodrine, and then had the frequent urinary tract infections that also associated with clinical worsening. So her symptoms worsened when she would have one of these episodes. And at year 5, she started using a wheelchair because of the increased falls and our orthostatic symptoms. And the midodrine was discontinued at that point. And there was a decision to place a suprapubic catheter. So this is a very fast-paced, progression of this specific case. So we will try to focus on the most important aspects of the evolution of this case. So the first one, I will let Stacy go over communication support therapy and also the issues with swallowing that this patient had.
Yes, so in regards to communication, there's a few options. I think earlier in disease progression, a patient can go to speech therapy, learn strategies, over articulation, increased breath support, things to try to make slurred speech sound a little clearer. As speech deteriorates more, strategies can be less effective. And so then we kind of move on to what we call AAC, or augmentative alternative communications. There's low-tech options as easy as printing out a piece of paper with commonly requested items that a patient can point to. Those are things that can be even implemented early and used throughout a disease course. And then there's high-tech devices. That can be something that you type into and spell things out depending on physical abilities. There's also eye gaze devices available, and that's best assessed for at a specialized AAC clinic because they have many devices available to assess with and can determine what's the most effective for one particular patient. In regards to swallowing, we see a lot of connection between severity of dysarthria or speech and severity of swallowing or dysphagia. Those things tend to correlate. As patients have more difficulty articulating their speech, they can have more difficulty coordinating movements for swallowing. And so those would be things that we would be assessing throughout the course.
All right. And Amy, what about the treatment options for someone with frequent urinary tract infections when they have it acute and how to prevent them? And also, let's talk a little bit about when to consider that suprapubic catheter placement.
Okay. So it's pretty individualized with all of these. The goal is to try and prevent these recurrent UTIs because they are unfortunately going to happen for a lot of different reasons. There's some urologists that kind of promote more chronic long-term antibiotics, just kind of a general, easily tolerated antibiotic. Some also our urologists here really like certain cranberry supplements that tend to be a little bit nicer on the gut than what the antibiotics can be. So we've kind of a little bit gotten away from the chronic antibiotics, but not in everyone. It just depends. But the goal again is to kind of reduce that rate of recurrence because a UTI really affects a patient for a long time. So we're trying to get away from that as much as we can. As far as catheter placement, again, it's very individual. Some patients, a lot of patients will start with kind of doing the in and out catheterization during the day. Some do just fine with that, and they find that they may only need to do it once in the morning and once again before bed, or kind of a tailored schedule. Some of those patients need to do that a lot more. And so for them, when that burden gets a bit higher, that's where the suprapubic catheter can really come into play. It's an actual external catheter that comes kind of through the belly. And so it feels a lot better than some of the other catheter options. I've had patients that go both routes and both do really well with it. Sometimes it's just the education that using that catheter is going to help prevent the recurrence of the UTIs, because when we've got so much urine just sitting in the bladder, it's really high risk for it to get infected.
Absolutely. Thank you for that. And then, is there a time to stop treating orthostatic hypotension? You know that.
Definitely can be.
Yeah.
So, early on, it tends to be a lot bigger of a problem because patients are a lot more ambulatory. But then we really have to continue reassessing the needs for these medicines and kind of scaling back on them as appropriate, because they may not be ambulating as much. And we might just be promoting supine hypertension all day and not really allowing for anything else. So again, that's an individual approach, but a lot of the time we'll be able to at least scale back on the pill burden. And that's another facet of it, of not having to take so many medicines so many times a day, especially when swallowing gets more difficult. So that's definitely something that we kind of keep looking at throughout the course.
Absolutely. I think that considering specific times where someone needs a support for blood pressure, especially transferring or doing chores like getting showers, or even physical therapy, it will be useful to have these. But otherwise, I think it's okay to scale back on this and reduce the doses overall.
Yeah, I've had patients that really like kind of pre-treating for physical therapy with imidazoline or something, and then that's kind of the only time that they need it. So it is different with everyone.
All right, very good. So we'll move forward with the next case. So study case number 2 is a 63-year-old female that used to be was a pickleball player who presented with a history of clumsiness that was noticed about 3 years ago when she was playing with friends. She reported multiple episodes of tripping and needing a few more steps to catch herself. 2 years ago, she had her first fall while playing pickleball that she attributed just to feeling dizzy at the time. And after playing for about an hour, her husband reported occasional episodes of choking while eating, and now they are occurring mostly daily. And she also felt like the food got stuck in her throat and needed to clear her throat frequently throughout the day. The other important thing that she had noticed was a change in her voice, with multiple family members asking her to repeat herself over the phone, especially. Um, and as a past medical history, she has some history of dream enactment that preceded over 10 years ago, with some kicking, punching, and yelling that occurred weekly until melatonin was started. She was endorsing also some urinary frequency and urgency, with no episodes of incontinence. And she continued to have balance issues and had to stop playing with friends due to unsteadiness and the risk of falling during this. She started using walking sticks to ambulate. That supported her balance and improved the risk of falling at that point. On neurological examination, she had positive orthostatic vitals, which means that her blood pressure dropped at least 20 millimeters of mercury on the systolic blood pressure. So went from 125 to 90, and then, about 12 millimeters of mercury in the diastolic blood pressure, with minimal change in the heart rate when she went from sitting to standing. She also had some dysarthria, or difficulty articulating words, with gargling sounds and muffled speech that improved after clearing up her throat. Her tone was increased in neck and all extremities, and had some difficulty aiming the target when she was doing the finger-nose-finger testing. And when we asked her to walk, she had a wide stance with multiple side steps to catch herself, and difficulty recovering from the balance test that we typically do during our visits. She also had a tilt table test that, to make it easy for you, as soon as we started doing the tilt, we see this drop in blood pressure that not only stays like that, but continues to worsen as the test went on. So after 8 minutes, she was tilted back because she had positive drop in the blood pressure up to 80 over 40 millimeters of mercury, with a pulse of 81 beats per minute. And she reported lightheadedness and unsteadiness during that time. She also had a skin biopsy that I think a lot of people is aware of it or has had it before, that was positive for phosphorylated synuclein in all three biopsy sites. So we can see here this bright red and yellowish coloring is the deposition of synuclein in the skin. So for you that have been aware of this, this is the way of the picture looking like along with your report. So you know that they overlap a few different layers of staining, and then this bright, sometimes red or yellowish color is the one that has the positivity of it. So those are the deposition of the synuclein. She also had a modified barium swallow test that was abnormal, and then we will ask Stacy to go over it so we understand a little better what happened in this specific image. And then there was an evidence of a contrast material entering the airway. So the diagnosis in this case was MSA, or multiple system atrophy cerebellar type. And then she had a few other things that we can gather from the history and examination that we got, like neurogenic orthostatic hypotension. Also had varying degrees up to severe dysphagia with aspiration and hypophonia, or decrease in the voice sounds and tone, and also had some mild urinary dysfunction, and also some other changes with dream enactment that was under better control there, and recurrent falls. So we will start probably with the swallowing difficulties, and then the importance of a test like the modified barium swallow.
Yeah, so a modified barium swallow, or also known as a video fluoroscopic swallow study, you may hear both, is an X-ray assessment of swallowing, so that we can actually see very easily what's happening when a patient swallows. So this test focuses on the oropharyngeal swallow. The oral phase is the mouth, and the pharyngeal phase is the throat. Once it enters the esophagus, that's the esophageal phase, and is better assessed with another test. But what we're looking for when we do a modified barium swallow is we're looking at how efficiently can a patient move things out of their mouth, how much is left behind in their mouth, what does chewing look like? And then in the throat, we're looking, is anything going up into the nose when they're swallowing? Is anything going into the airway when they're swallowing? And is anything left behind in the throat after they're done swallowing? And so when we're looking at this image specifically, I don't know exactly what consistency this is that was given, but likely a liquid would be my guess. When we do the test, we give a variety of consistencies of a contrast called barium, usually thin liquids, thickened liquids, a pudding consistency, and a cookie or a cracker dipped in some barium. And it's a live X-ray while a patient is swallowing all those consistencies. So this is just a still image that was captured from the video. And what I can see just looking at this still image is that you can see the majority of the bolus, the majority of that darkened area, that's the contrast, that dark stuff is going towards the back. But that little bit that's going down towards the front, that top part is the opening to the airway. And then right where it kind of has those two dots next to each other, yep, right there, that's about the level of the vocal cords. And so once it falls below the level of the vocal cords, we call that aspiration. Aspiration, if it's happening frequently and a patient is less mobile and immunocompromised, can turn into a pneumonia. And so the point of doing this modified barium swallow is we can see, first off, is a patient aspirating or not? What are they aspirating? Because patients often will aspirate one consistency, but not something else. Why is it happening? And then what can we do about it? So sometimes all it takes is a little bit of diet modification, changing the consistency of the food or liquid. Sometimes postural strategies, turning your head a certain direction, can help. Some patients do well getting rid of a straw and just drinking from a cup. That's their strategy. We can't really figure out what strategy works the best until we do this assessment.
All right, very good. So the other main concern that we had for this patient was the management of the orthostatic hypotension. And in her case, it was neurogenic in nature, meaning that there was little to no change in the heart rate when the changes in position occurred. Normally, we have an increase in the heart rate as a normal response to try to adapt to those changes in the blood pressure going from sitting to standing to support that blood pressure and tightening the blood vessels. But in this case, it didn't happen. So, Amy, what can you tell us about the importance of non-pharmacological strategies for addressing this type of issues?
So there's going to be a lot of different choices when it comes to this, and no two patients are the same with what works or what doesn't work. There are several medications that we can use for this, and it does often require a combination of more than one, not always, but more often than not. All of these medicines kind of work in different ways. I've got kind of my own personal favorites and go-tos, but I use all of them because they just don't all work at the same time or as well as each other. So the thing with her, I don't think that we've got documented supine hypertension, so I'm not as worried about that, but I definitely want to get her daytime blood pressures higher. So for her, I would most likely start with something like a pyridostigmine or a midodrine, and have her do some homework and check those blood pressures at home and send them back to me so I can titrate from there. Most of these medications are going to be taken 3 times a day, so you can't really get away from that. But they all can work pretty synergistically as well.
And along with medications, the other 3 main pillars of treatment are water, salt, and exercise.
Water.
I think it's going to be very important, and we have a lot of other symptoms that may limit the ability to do that. So I think that tackling multiple areas at the same time is useful. So swallowing is also something that we need to improve so they're able to keep a good hydration. And in this case, Stacy, would you think that if someone has difficulty with thin liquids, the strategy will be to thickening the water, which is something that may help them to stay better hydrated?
Potentially, yeah. That's often a recommendation.
And then also, salt intake. I think salting the foods, as opposed to most of internal medicine providers and cardiologists, we are pro salt in most of the cases because it helps retaining water within the main vasculature, and that provides a degree of volume expansion that helps keeping that water from just urinating and helps with the symptoms. And then exercise is very important. Now, when we talk about exercise, a lot of people think, well, jogging, doing treadmill, standing exercise. But in these cases, if you have neurogenic orthostatic hypotension or orthostatic hypotension overall, we need to avoid having these changes in position or doing standing for a long period of time. So the type of exercise that we should be doing is sitting down or laying down. The most important types are the recumbent exercise with a recumbent bike or a rowing machine, but also water. Exercises in water are good because the water with the hydrostatic pressure will support your blood pressure and it's less likely for you to have symptoms then. You do have to be careful once you exit the pool because that's when you may feel lightheaded. So you have to take your time when doing that. And of course, stay well hydrated then. And then we're going to try and tackle some of the strategies for recurrent falls. So Amy, when you are trying to refer someone to physical therapy, what are your main goals to for safety?
Really working on balance and education for the physical therapist. We run into this a lot where they're just not as familiar with MSA. And so kind of taking some time to adapt the orders to more of just kind of balance training, gait therapy, really getting kind of specific with it. It can even be range of motion exercises if they're immobile. But also kind of setting the tone that we don't expect necessarily improvement. I'm just trying to keep them where they are for as long as I can. And so maintenance is the goal with this. So I think reframing that for both the patient and that PT provider is really important, but absolutely working on balance. Sometimes patients will do, like the rock steady boxings that usually goes with Parkinson's, but a lot of patients, if they're able to tolerate that, enjoy it as well. So it's really just finding what works for them. It also depends on where they are in the disease, of course, but when they don't know how to safely exercise on their own, that's really where I can get a physical therapist involved to give them some of that confidence and figure out what can we do. The recumbent bike is absolutely huge.
Yeah, absolutely. I think that gait safety is important, but the other point that you mentioned that is very valuable is keeping the function that you have. It's unrealistic at times to get you or improve you in a significant way, but you have to think it the other way around. If you're not doing physical therapy and exercises on your own, you will continue to deteriorate. So keeping that balance and keep you stable is one of the most important things in this case. So we will move forward with the next case. So for case 3, and this is just the additional key features. We address the severity of dysphagia and the frequency of falls, also the blood pressure fluctuation management, and the use of walking assisted devices. That's another thing that we will probably get into with the next cases as well. And some difficulty with activities of daily living that also physical therapy and occupational therapy are able to help to adapt to the issues that you have right now and trying to look a way around it. So you are able to perform those chores with some modifications. Sometimes it's tools, sometimes it's other ways of performing the activity. Easiest example is if you are unsteady or dizzy when you shower standing, you need a shower chair, for example. And that is a very easy and safe strategy for you to address that specific activity of daily living. So moving to case number 3. So this is a 57-year-old man with history of hypertension and hyperlipidemia that presented for evaluation of lightheadedness. His symptoms started about a year ago and were characterized by, transient lightheadedness upon standing associated with some darkening of the vision, after climbing a flight of stairs, and also when going or standing up from squatting. 6 months ago, before this presentation, he noticed a fine tremor in his upper extremities. He had also a history of dream enactment since age 49, and it was confirmed by a sleep study that confirmed the REM sleep behavior disorder. And he had erectile dysfunction that began a year prior to that with some worsening in the bladder function. He did have a TURP, or a transurethral resection procedure of the prostate, and became incontinent, after which they initiated a clean intermittent catheterization. These are his medications. He's on lipid medication. He's also on a couple of blood pressure medicines, including lisinopril and amlodipine, and also tamsulosin for the bladder issues or the urinary incontinence, and he is on a B12 supplementation. On neurological exam, we had some decreased facial expression with difficulty articulating words and some neck in the forward flexion. His tone was also increased in all extremities and had a jerky tremor in his arms when he held them in posture, consistent with what we call myoclonus. His gait was characterized by some shuffling steps and had some reduced arm swing bilateral. So his autonomic testing showed a heart rate response that was decreased, and also during the tilt table test, there was a drop in the blood pressure that was significant, going from 168/86 to 72/48 after 5 minutes of the tilt. And he did not experience any symptoms. We also had some thermoregulatory sweat tests that show global absence of sweating and some light sweating on the armpits. So this is what happened, and this is just the reports from the autonomic testing, but we can see here that there's a couple of abnormalities with some decrease or drop in the blood pressure again that was consistent throughout the tilt until it was stopped. And then also there was an abnormality in another test that is called Valsalva maneuver that tests for the sympathetic adrenergic, or the response to these changes, where we don't have a recovery or overshoot in the blood pressure after that sustained breathing or effort is performed. So the diagnosis in this case was multiple system atrophy Parkinsonian type. And we are going to try and talk about the management of the neurogenic orthostatic hypotension with the supine hypertension, urinary dysfunction, and the high risk of falling. So Amy, if you want, we can try about what will be the first step that you will do in someone that experiences this type of drops in blood pressure.
Yeah, with that significant of a drop, I'm definitely looking at medication list first, so I can edit down what he's on right now, or he or she, with the lisinopril and amlodipine to get rid of those. That will help, but I don't think that's going to be enough in itself without adding something to help raise his blood pressure up. So first would be getting rid of those. Second would be starting something during the day to help keep blood pressure higher. And then another medicine at night to actually keep him lower while he's laying flat overnight in bed. That really helps. It sounds counterintuitive, but it really helps the next day from them having to swing kind of so low and so high. And that, I've learned, kind of keeps things a lot more even keel throughout the day if we treat that supine hypertension. So that's not something to ignore. The tamsulosin is also a little bit worse at lowering blood pressure than some of the other medications that we can use for urinary dysfunction. So that would be something else to look at. I try to not make too many changes at once. So we'd probably kind of stepwise with how we're doing this, but definitely addressing that blood pressure is my number one priority.
Yeah, because that will incur multiple other things, right? Especially
Right.
the fall risk, which is the immediate next step, not only because of some of his difficulties with movement, but if he just has a syncopal event and falls, he may end up in a fracture of, a hip fracture or a brain bleed if they hit their head. So it's a very important thing. And, talking about this, other issues that people may present, and since we have here some time to address it, Stacy, can you just go over with us with some general strategies for someone that has some swallowing issues, or the main strategies that you employ or recommend them for a safe swallowing?
Yeah, so I think there's some what we call standard aspiration precautions that we recommend for our patients who have any level of dysphagia. And that would include sitting upright when eating and drinking, ideally in an upright chair at a table. It's the most natural way to eat. That's how it helps. Gravity is then in our favor, helping things move through the GI tract. Eating at a slower rate, trying not to put multiple bites of food in your mouth at once, trying to limit distractions as much as possible. It's difficult. Eating is a social experience. We all talk when we're taking in a meal, but instead of in a recliner watching TV, which is very distracting and in a suboptimal position, sitting at a table, trying to listen to conversation, taking a break from eating when you want to participate in conversation are some things that we tend to think about.
Very good. Yeah, and then I think the other important thing to address here is to understand the severity of someone's urinary dysfunction. There needs to be some other strategy. So sometimes, you know, if someone experiences some urgency, frequency, or even a degree of incontinence, we need to get to the root of the problem and see what's the main issue affecting this. If it's related to an overactive bladder, if it's a difficulty with the sphincters. So there are a few studies that urologists perform that are called urodynamic studies that will be able to let us know what it is, and then we can address it. As Amy was saying, you know, Flomax is one of those medications that affect that normal response to activate when you go from sitting to standing position. So there are some other alternatives that you can discuss with the urologist that will not affect the drops in the blood pressure as much. But I think among most of the medications, Flomax is the one, or tamsulosin is the one that incurs more into it. And then we had here the additional key features that we talked about. So medication review, the swallowing and degree of dysphagia. The other thing that can come up with some of these aspiration events is also respiratory issues when they have, you know, an aspiration pneumonia, which is why it's so important to address this. And a lot of these patients can also have what we call a respiratory stridor, which means that when they're trying to pick up air, there's a high-pitched sound that interferes with it, which it's very detrimental to the life expectancy of someone with multiple system atrophy. So that needs to be addressed. And the adequate referral to an ENT will be very useful, because there are some other strategies that you can have to cope with it and have a safer breathing in that sense. Physical conditioning is also very important in this case, with you know, round of physical therapy, again, adapted to the accommodations for changes in blood pressure. So typically this physical therapy is recumbent, so laying down, sitting up, or at a tilt to help with it. And also the caregiver and family support that is always very useful in all of the strategies to see how to perform and learn how to do this type of exercises so they can guide patients in this regard. So we talked about the early interventions here already and the appropriate referrals for this patient, and then we're going to move on to our last case. I think that we do have a few minutes, so we'll try to tackle it in. So this is a 61-year-old man with history of hypertension and sleep apnea that presented for evaluation of rapidly progressing slowness of movements. For 4 to 6 months, he had a change in the walking that was slowed down, and then also developed a small hand tremor in both hands that interfered with the activities. He also was told that he had a poker face and had 2 falls that he acknowledged or thought that it was related to imbalance. He did not have any dizziness upon standing, but was very fatigued during the day. And also had mentioned some mild constipation, but no urinary symptoms or loss of sexual function. Examination did find slow and rigid type of Parkinsonism without orthostatic hypotension. And then he also had some imaging and other work that was negative. He did have a skin biopsy that was positive in 2 out of the 3 sites. So we can see there the change in the synuclein in the posterior cervical region, which is here at the back of the neck, and then also in the distal leg. And he did have levodopa that improved his movement, but did not change anything significant on the Parkinsonism. And this is just the clinical course. So year 2, he had some more bladder issues and loss of sexual function, worsening fatigue that did not respond to medications, and then he started developing more memory issues. At year 3, he had new freezing of gait with falls that were occurring all the time, and also had to start using a walker. And then year 4, The urinary and gait worsened with daily falls requiring beginning the use of a wheelchair, and then the swallow evaluation was consistent with a silent dysphagia. Levodopa continued to be mildly beneficial, so he continued to take. We're going to start in this case by talking about what do we mean by silent aspiration or silent, dysphagia.
Yeah, so silent aspiration is when a patient aspirates, food or liquid goes down the wrong pipe, and they don't have a response to it. So I think probably everyone's experienced when they're drinking, something went down the wrong pipe, they cough and cough, their eyes start to water, the face turns red. That's a typical response. But we know that in patients with MSA, their sensation can be altered, and therefore they can be aspirating without a cough response. That's more dangerous because then they're not coughing that out of their lungs. And so that's where the modified barium swallow comes into play, because we can see what's happening and we don't have to be looking for external signs. We can see it live on X-ray. We can see exactly what's happening in the throat and determine based on what we're seeing what the right next steps would be.
Yeah, and one of the main difficulties is that this can reoccur over and over until we figure out why. And it's very important for us to be aware that any infection or metabolic issue will worsen your symptoms of MSA. Not only the motor symptoms, if you have, for example, slowing or tremor, but also the blood pressure issues. Okay, so that is a very important thing and might be the first clue. So it's always important to have a baseline swallowing evaluation to rule out that this is related to a potential silent aspiration, that you're getting an infection type of response from. So also I wanted to just mention that for frequency of motor predominant MSA, so on the studies that have been conducted, about 73% of cases, or more or less 70%, start with a motor onset. Okay, so they have some degree of tremor, slowness, stiffness, or walking difficulties with some early falls that may happen, and then also have the risk of developing other things like bladder symptoms and orthostatic hypotension within the next few years of this. Some other patients actually start with having orthostatic symptoms and bladder issues and then progress to have some of the motor symptoms. So the presentation can also be very variable. And then it's important to have someone to diagnose this and have the adequate diagnostic testing in this case, which now in the last few years, the skin biopsy has become one of the tools that we have to determine the presence of this protein that makes it more likely for this to be a multiple system atrophy in the right setting. So the other thing that we can talk about is what do you think, Amy, about prioritizing the urologic symptoms and erectile dysfunction versus the management of orthostatic hypotension, and how they can play a role between each other?
Yeah, I think it's again pretty patient specific, and we just have to look at what's the kind of more prevalent issue of the moment. So the two, like treating one can make the other worse and vice versa. So we kind of have to look at it as a whole. I like to get urology involved early because I want to get those urodynamic studies. I want to know what's really going on, because we can be chasing a problem and not really knowing what the cause of it is. There's a lot of different treatments with Botox and kind of different things that urology can do, but that's why it's so important to get them involved. And it also helps us weigh out, okay, how do we treat one without worsening the other as much as possible?
That's right. Yeah. So, and that again has a lot of importance of how to communicate between subspecialties, which I think that's one of the main benefits of having a multidisciplinary team in the centers of excellence, if you have one nearby, because they will increase your chances of getting this communication among subspecialties to improve this conditioning and not just one pulling on one side and the other one in the opposite direction in this case. So with this, we will close in the case discussion and we will move on to the questions, but I just want to have this conclusion. The collaborative care is essential to address the multisystemic nature of MSA, reducing the caregiver burden, which is a very prominent thing that may happen if you just have one person that is taking care of you, and providing them with a support system to caregivers, but also patients through the progressive course, and giving back some dignity and clarity. So we will go ahead and open it up for the questions that we have.
Thank you all so much for that presentation. That was really great. We do have a few questions from folks, and for those of you watching, please feel free to keep submitting those here in the next few minutes. But we'll start with this question, which is, what do you think about using like a like a trainer instead of a physical therapist?
I think you can use both. It really just depends on, cost. That's a big factor with this. Physical therapy, we can often get at least somewhat covered by insurance, where a trainer is going to be out of pocket. I think there's utility in both of them. So if we have the ability to use both, absolutely. More movement is better.
Yeah, and I do think that it's also very important to have someone that knows about this type of conditions, because someone that is a physical trainer, that they do have expertise in, conditioning people without some of these issues. But if someone has neurogenic orthostatic hypotension, they won't be able to do the same conditioning. So they need to know about the disease and how to do those modifications to be able to help you as a trainer.
Yeah. Thank you both. Another question for you. How do you go about creating a team of MSA health practitioners when the patient is in a nursing home?
Yeah, I think that is, it's a difficult scenario, but I think it's still, if there is a possibility of having that person coming at least into evaluation. There are some centers of excellence that have a multidisciplinary care sessions where they have a half a morning evaluation of a specific case that will be provided and consolidate all this expertise into a half a morning. Sometimes that is doable. Instead of having and referring people that you will see spread it across over a month, that may make it a lot difficult with transportation and everything. So if your center or a center close by has the ability to perform that, it will be much more useful for you. And then even being on a nursing home, if you're able to get out of that nursing home for that specific time and then have all these evaluations, then it can provide you valuable information to get back and then start working on those aspects.
Mm-hmm. One person asks, how do I approach the neurologist treating my family member that we want a collaborative team, and who on the team coordinates that care?
I think you just have to ask, and it can be something of saying, we come here from a long way away. Can we try and just see as many people as possible? Sometimes a clinic's set up where we can preemptively be aware that someone's coming from out of town and kind of make plans for that, but that's in a perfect world, so that doesn't always happen. So the patient their family member has to really advocate for that and just start with, we've got a neurologist. Who else could we see here? Or do we need to see someone locally? Can you refer us to someone locally? We're happy to work with providers in the community, but we just need to know that there's an issue, and then we can try and do whatever we can to help facilitate that care.
Yeah, thank you for that answer. Another person asks, is there a benefit in continuing speech therapy and physical therapy during the sort of final stage of MSA? For example, when a patient is bedbound, nonverbal, on a feeding tube, etc.
I would say I think there are still some strategies and education that can be provided, even just to the caregiver on ways that, like a physical therapist can assist in some passive range of motion, some stretching. Speech therapy can help assist with appropriate ways to provide oral care that can reduce risks associated with aspirating. So I do think there is some benefit.
I agree. I think that throughout it should be beneficial, you know, even with passive movement and as much as the patient can collaborate, even if the therapy is in bed, it's okay. And that is something that is expected because any type of muscle activation will be good to help improving the blood pressure to an extent. The muscles that are not used get atrophied, and then the degree of blood pressure issues may worsen then. And going along that, I would like to touch quickly about the coat hanger pain that people experience. So that typically comes in and can be presented as one of the symptoms of orthostatic hypotension because of ischemia of the trapezius muscles in the neck. Okay, so that's why you have it in between the shoulder blades, and that is just a manifestation. Not everybody has them, but if you do, then that means that those muscles are not receiving enough blood supply during these changes in position, and that's why you're perceiving it. So if that's one of the most bothersome symptoms that you have, then you should address this orthostatic changes to help mitigate the amount of the drop of the blood pressure.
Yeah, thank you. Here's another question sort of related to speech therapy, but what specialty should we consult for a modified barium swallow test?
Yeah, so the test is performed by a speech pathologist. It's also performed in conjunction with radiology. So it's beneficial to be seen by a speech pathologist either before and or after the modified barium swallow, but you can also be referred directly to the modified barium swallow itself by your provider. But it's helpful to have that follow-up, especially afterwards, to go over the results and then implement anything that was recommended on the assessment.
Yeah. Another question might be, how does one determine which subtype of MSA they might have?
A lot of it just depends on kind of what your presenting symptoms are. As we get later in this disease course, a lot of the kind of MSA-P and C meld together. We get a lot of overlap, so that can get a little bit more difficult. But it's sort of, what were the first things that you noticed? Was it more of this kind of blood pressure, difficulty speaking or change in speech, swallowing, urinary dysfunction, or was it this kind of treatment resistant Parkinsonism, meaning like I got diagnosed with Parkinson's, I got put on Cinemet, and I just didn't get any better. And that can often be more of the MSA-P. So a lot of it is just that kind of initial presentation and what you look like and what you come in with. There's not necessarily a specific test that will say which one. An MRI can help lead us down both of those paths, but that's not a perfect thing either.
So clinical evaluation is the key, and important along with that is follow up, because these symptoms can develop or be more clear as you know the evolution of the disease presents itself. So it's very important to have this continuous evaluations to determine these other symptoms that may be presenting and address them as quickly as they arise.
Yeah, thank you. Someone else asked, they said that they've been working on getting a Tobii device for over 2 months now. Is there something that can be done to make that process quicker? And then they're also asking, isn't it better to start that process sooner rather than later, since they know that speech deterioration will happen? Should it be sort of started more toward the onset of the disease rather than later?
Yeah, I think that's a great point. Unfortunately, getting a speech generating device is not a quick process. I unfortunately don't know any ways to speed that process up. It's a complicated process that involves insurance loopholes and things like that. Certainly, the earlier the process is started, then the sooner you'll have the device. Access methods may change if you get it early. You may start using it just with one finger. It may need to be adapted as symptoms progress and maybe mobility changes, but that certainly can happen.
Mm.
Sounds
Thank
very
you.
similar to wheelchairs. It takes a really long time to get a custom wheelchair. So starting the process early is very beneficial.
Someone else asked, what type of radiology tests are used to help diagnose MSA, MRI, PET scan, etc.?
I think from the radiology standpoint, there are two main things. I think a baseline MRI will be useful. Sometimes we may have some changes in the brainstem that are what we call the hot cross bond sign, that it's presents as the brainstem atrophies, and that is one clinical clue, but by no means is a hallmark of the disease in the sense that we don't see it 100% of the times. And the other one that I think overall is more useful is the DAT scan, or dopamine transporter scan, that can let us know if there is a type of neurodegenerative Parkinsonism that is happening. So if this one's positive, then it indicates that there is a neurodegenerative process occurring in the brain that will potentially be associated with the symptoms that the patient has.
One person is saying that their sister was recently diagnosed with MSA and a year ago was initially diagnosed with POTS and no further evaluation was conducted. And they're asking, shouldn't symptoms like that signal a need to look at other illnesses like MSA?
Not always. That's one reason why this disease is so complicated. It doesn't present in the same ways with any two people. And POTS can certainly look like neurogenic orthostatic hypotension and vice versa. So it's not necessarily that something was missed with that. It just sometimes takes time. And I know that's not what anyone wants to hear, but that's just the truth of it. And so, getting established with someone and then kind of going back and being that advocate for yourself and saying, hey, I'm not getting any better. Could something else be going on? That's the best that we've got at the moment.
It is important to determine if you have any other type of autonomic dysfunction, along with the diagnosis of POTS. And I know that autonomic testing is very limited countrywide. So it is something that may be months in the queue. But if you're experiencing some of these symptoms, they can address them with some cardiovascular reconditioning, specifically for POTS. And then the last thing I wanted to touch on is for staging. Stages are typically for research purposes, okay? And people may fluctuate, especially if you respond to one medication or other, or if you respond to therapy. So don't be so hooked on thinking about I'm stage this or that, but based on the issues that you have and how to address them with the different parts of your team.
Thank you. Our last question for today is going to be, have you seen positive results in MSA with stem cell therapy?
It's a hot topic.
Yeah, definitely. So
I haven't personally. I think you've got to be really cautious with these things. There's been some really bad outcomes with stem cells if you're going somewhere that's not above bar. So it takes a lot of research on the patient's end. I'm not absolutely opposed to it, but I also say you've got to really do your research about what you're doing. A lot of these are injecting something into your spinal canal, so it's not just risk-free. And so you've really got to take that into account.
Absolutely. There's nothing that has been approved so far. So I don't think that we're able to recommend any of these at this time. I mean, that might change the way that technology and the new ways of treating neurodegenerative conditions advances. But as of now, there's nothing that will show a potential benefit in humans. So we'll take a hold on that, and we may need to revisit it later. Okay. So, and then I'll just tackle the other two. So for people that the Cinemet doesn't work, are there any medications that provide relief? So typically, if you don't work, if Cinemet doesn't work with you, that means that the motor symptoms will not be addressed for any of the other medications, because they may just induce some of the side effects instead of the benefits that we're expecting to have. So I think focusing on the other issues, especially if you have blood pressure issues, will be our main goal, because some of it, if you are lightheaded or you have orthostatic hypotension, it may affect your gait, it may affect your cognition. So all of those things can be addressed if you do have an adequate blood pressure. And then coenzyme Q10 has not shown to have any benefit overall in the slowing the progression or helping. Sometimes with a bunch of these medications, there is also a big what we call placebo effect. So if you take them, you think that they get better, and you may have a subjective improvement on this. But so far in the studies that we have conducted over time, it hasn't shown that that's the case.
Awesome. Thank you all so much for both the presentation and for answering all those questions. I know a lot of folks found that really helpful. And we're just, we're so grateful you guys could be here and give us this presentation today.
Absolutely. Thank you for having us.
Yes.
Of course. For those of you watching, I would love for you to stick around for just a quick second. I'm going to send out a feedback survey that should pop up on your screen here in just a moment. It's just 2 quick questions, but it just helps us to plan for future webinars. So if you wouldn't mind filling that out really quick before you jump off, that would be awesome. Thank you so much for being here. And again, the recording of this webinar will be uploaded to our resource library.